I will be talking about my presentation at the last EBMT meeting in Glasgow on haploidentical transplant in lymphoma. So, when looking to the EBMT registry, actually, we have witnessed in the recent years decreased transplant activity in Hodgkin lymphoma, as well as decreased allogeneic transplant activity for non-Hodgkin lymphoma. So in Hodgkin lymphoma, that decreased transplant activity is due to more efficacious first-line and second-line treatments. In non-Hodgkin lymphoma, it is because of the exponential increase in CAR T cell activity that has replaced transplant activity in many indications. However, where within the allogeneic transplant activity, a significant percentage of patients are getting their transplant from haploidentical donors. And actually, thanks to the development of post-transplant cyclophosphamide, we reported in 2020 the EBMT results or experience with haploidentical transplant for lymphoma by histology, and the results in terms of 2-year PFS were excellent for Hodgkin lymphoma, follicular lymphoma, peripheral T-cell lymphoma, and mantle cell lymphoma, all exceeding 50%, with somehow lower results for diffuse large B-cell lymphoma. So overall, when we look to the published results with haploidentical transplant in relapse refractory Hodgkin lymphoma, we can see 3-year PFS around 50%. And in the early days of haplotransplant, in the Italian experience, haploidentical transplant and relapse refractory Hodgkin lymphoma gave superb results for patients who were transplanted while in complete remission or partial response, with a much less favorable outcomes for patient transplanted in stable disease or progressive disease. And then this new source of donors for transplant was compared to other sources. And actually, in the Seattle experience, haplotransplant was associated to lower extensive chronic GvHD, better PFS in relapse refractory Hodgkin lymphoma. And in registry studies, in the EBMT registry study, haplotransplant compared favorably with sibling donor, match unrelated donor, and similar results were reported from the CIBMTR, as well as from the French Society for Bone Marrow Transplant, where the combined disease-free, GvHD-free endpoint favored haplodonor over sibling donors. Similar results were also reported in non-Hodgkin lymphoma, with a 3-year PFS around 50% overall in multiple publications. Again, in registry studies, haplo compared favorably with sibling and much unrelated donor in relapse refractory non-Hodgkin lymphoma, in the EBMT registry and in the CIBMTR registry, with a drastic decrease in chronic GvHD in haplo versus HLA identical siblings. And even when compared to match unrelated donor, whether ATG was used or not, haplo was associated with improved outcomes in the EBMT and in the CIBMTR registry, particularly in terms of decrease in chronic GvHD. And finally, haplo was compared to cord blood in a joint EBMT Eurocord CIBMTR registry, and performed much better than cord blood in this combined analysis. And a randomized trial was even performed by the BMT CTN group comparing double umbilical cord blood transplant versus bone marrow haplotransplant. And the results showed that haplo was associated with improved overall survival, decreased non-relapse mortality, and so overall better outcome. However, when looking to these data, the contribution of haplo versus the GvHD prophylaxis modality used in haplo, which is post-transplant cyclophosphamide, were not well defined. So what is giving these excellent results? Is it the haplo itself or the PTCy? And actually, we had a first hint from Hodgkin lymphoma when doing allogeneic transplant after checkpoint inhibitor. Improved outcomes were observed when using PTCy, regardless of the type of donor, in univariate and in multivariate analysis. In other words, patients who were allografted in Hodgkin lymphoma after checkpoint inhibitor, they had better outcome when they had haplo PTCy, match unrelated donor PTCy, so and much lower outcome when they did not have PTCy. So apparently, in the setting of checkpoint inhibitor use as bridge to allo, PTCy is mandatory. Then, more recently, last year, a joint study of EBMT and CIBMTR compared haploidentical versus match unrelated donor transplant using post-transplant cyclophosphamide for lymphoma. And this joint study reported that haplo had less favorable results versus MUD in overall survival, PFS, non-relapse mortality, platelet engraftment, acute GvHD, and chronic GvHD, whereas no significant difference were observed in terms of relapse and neutrophil engraftment, which means that when using PTCy, then full match donor are better than haploidentical donor. And in the same sense, another study from the EBMT Lymphoma Working Party that was just published a few weeks ago retrospectively compared the outcome of allotransplant from HLA-matched donor and haplo donor, all using PTCy-based GvHD prophylaxis in patients with Hodgkin lymphoma registered in the EBMT database between 2010 and 2020. And in this study, haplo transplant was associated with a significantly lower rate of platelet engraftment and a higher rate of grade 2 to 4 acute GvHD. Conversely, the 2-year non-relapse mortality was significantly lower in the HLA-matched cohort compared to haplo, resulting in higher overall survival. And in multivariate analysis, haploidentical transplant was associated with increased risk of grade 2 to 4 acute GvHD and non-relapse mortality and worse overall survival. So in conclusion, for haplotransplant in lymphoma, haploidentical donor, using haploidentical donor will allow almost 100% of the patient with relapse refractory Hodgkin lymphoma or non-Hodgkin lymphoma who are candidate for allotransplant to be able to get into the procedure. The post-transplant cyclophosphamide platform has significantly simplified the procedure in terms of morbidity and mortality, allowing its widespread use in different settings. They are less expensive than MUD and cord blood, the haplo. In the setting of prospective clinical trial, haplo is associated to lower non-relapse mortality, better overall survival compared to double cord, Long-term results similarly or eventually favorably compare haplo with match unrelated donor and even with HLA identical sibling in early days, but recent evidence suggests that in the context of PTCy-based GvHD prophylaxis, transplantation from HLA-matched donor appear to be more favorable option compared to haplo.